You have to realize this is happening at an epidemic proportion.
It's really widespread. We have people who are sick, all right? These are not scumbags, and it's our job to take care of them.
It's a lot of individual responsibility being placed on these people, and shame and guilt.
As we talk about an epidemic, it feels so insurmountable. But then when we think about just doing something small today, that's how we get these pebbles rolling and hopefully making a bigger difference.
I'm Julie Rose, and this is Top of Mind. I have been a radio journalist for 2 decades, but a few years ago, I found myself avoiding the news for long stretches because of how depressing and divisive it all seems. I still wanted to be informed and engaged on important issues, though, and I figured I couldn't be alone in that. So we created this podcast. Each episode, we tackle one tough topic in a way that will challenge you, help you feel more empathy, and empower you to become a better citizen, a kinder neighbor, and a more effective advocate. Today, what's the point of calling big social issues epidemics?
This is a young man who was in his 20s who came in, he was shot in the chest and he was shot in the face. And I wound up pronouncing him dead in the emergency department.
Rob Gore is an ER doctor in Brooklyn.
1 or 2 minutes after that, I ran into the next room and I took care of another young man who was shot multiple times. But when we rolled him to assess his full body, I noticed that he had scars on his back, showing that he had been shot in the past. What I also found out is that the guy who I pronounced dead a few minutes before had shot the guy in the back a few years prior.
Violence, Dr. Gore realized, was contagious.
There were at least 3 shootings that took place. The first one, where somebody got injured a couple years prior.
So that's how the guy who survived in the ER that day got that old scar on his back.
The second one, where another person winds up being killed.
That is the guy Dr. Gore pronounced dead.
A third shooting, where the guy who was shot 2 years before was also there as the recipient of some sort of violent act on them.
Now, Gore never learned if the 2 men who came into the ER had shot each other that day or if somebody else was involved. But he knew for sure the circle of that violence was much wider.
Those are only the people that came to the hospital. There were other people that were involved in the shooting itself.
Maybe as shooters, maybe as intended victims, maybe innocent bystanders, or family members of the men in the ER that day.
These incidents that are happening are not just one time only, but have an ability to continue to replicate themselves. As a matter of fact, when somebody gets shot or stabbed, the rate of a recurrent injury is close to 50%, and that rate of being killed is as high as 20 to 30% within 5 years after that initial injury. I look at these things as epidemics, much like any other disease process. If you look, just looking at how viruses replicate. All you need to do is have the perfect environment to foster growth and development. That same thing applies to violence.
Rob Gore has written a memoir called Treating Violence. An emergency room doctor takes on a deadly American epidemic. And his use of the word epidemic is intriguing. These days, anything that's widespread might be called an epidemic. But in the public health space, the label epidemic carries special significance beyond that. It's a disease that's widespread and usually contagious, too. Today on Top of Mind, how does thinking about social issues like obesity or opioids or loneliness as epidemics change the way we approach them? We'll explore the pros and cons with first responders on the front line of each of those epidemics. What changes if we think of opioid addiction as a disease rather than a crime or character flaw? In what ways is loneliness like a disease? And what's the prescription? Obesity got official epidemic status in America in the 90s, and yet obesity rates have only increased. So what's to gain by viewing violence as a disease epidemic, as Dr. Rob Gore suggests?
Homicide is the number 1 cause of death for Black men ages 15 to 34. That means Black men in that age category are more likely to die from homicide than they are to do from HIV, accidental injuries, even COVID during peak times. Violent incidents can take place at any place on the planet. But the continuous nature of these incidents tend to take place in places where the community's needs aren't always met.
Like Gore's home borough of Brooklyn, where close to 3 million people live. Most are Black, poverty is high, and so is the rate of hospitalization from violence and assault.
Just like any other infectious disease, if you are in close proximity to someone that has an infection, that increases the likelihood of you catching that infection. I got jumped when I was like 11 years old. I got robbed by two guys that came up from behind me and stole my bus pass and stole like the dollar that I had in my pocket. And it was unnerving. I didn't know them. These weren't neighborhood bullies that I had encountered before. These are two people that just grabbed me up at the corner of my block and stole something from me and beat me up. And so I started carrying razor blades and screwdrivers to school from age 11 up to 18. And I wasn't the only one. A lot of my friends carry weapons. Some of them carried guns a little bit later, not necessarily in middle school, but in high school, some of them carried guns. What I see as a part of my practice is I may have somebody who, if their money situation is less than optimal, how do they pay for medication? How do they pay for healthy food? How do they get to and from work? When you don't have some of these elements in place, they create an unnecessary amount of stress on the human body. When these stressors continue to happen without an ability to process and without any sort of rest or recovery period, the body starts to break down. And whether it's physically or mentally, which is why somebody who's, let's say, we were involved in a conflict and I'm well rested, I'm well fed, I'm not worrying about how to live tomorrow, I can process the disagreement that we've been having a lot more easily. But if I don't have that, I'm hyper vigilant, I'm on edge, and you step on my shoe or you say something to me that's not really favorable, I'm going to attack out and I'm going to be the aggressor because I'm looking at you as a stressor. And when we see something as a stressor, we often respond aggressively because we go into fight or flight mode and we go into a protective mode.
How did you manage to escape that cycle?
I had support. My mother's a teacher, or a retired teacher. My father has a background in television, media, and communications, but he's also an activist. And so I had that support system in the home environment. I happened to go to schools that were 100% very supportive of me. And I think because I also performed well academically, people gave me even more support.
And so when the title of your book is Treating Violence, an emergency room doctor takes on a deadly American epidemic. So if violence is the disease, trauma is the pathogen that causes it to spread rampantly in some communities like the one that you practice in, what are you treating exactly?
So the first thing is, how do we keep this person alive? How do we keep them stabilized as long as possible until the trauma team and the other surgical services can come in and intervene? And that's usually what we call the first golden hour of trauma. And if you intervene in that first hour, the likelihood of that person staying alive and having a better health outcome is a lot higher. Dr. Carnell Cooper talked about the second golden hour of trauma, and that relates to violence intervention. And meaning if we at least provide support for victims and survivors of intentional violence, we can help prevent retaliatory violence from occurring.
At Kings County Hospital in Brooklyn, that work is done by violence intervention specialists who are on site 24/7 through a nonprofit Dr. Gore formed called CAVI, which stands for Kings Against Violence Initiative.
So Benny Johnson was our first violence intervention specialist. Benny and I met in the emergency department because his son got bit by a dog. And I also noticed that Benny had a large scar across his cheek. And I asked him, I said, what's up with this? What happened to the scar? He's like, oh, that was from a former life. He had been involved in gang activity. He had been shot and he'd been stabbed before. So I was like, wow, this is the perfect person we're looking at. And I also liked how he engaged with his sons. I liked how he talked with people in the hospital. And I thought, he'd be perfect. He's almost like the prototype for what we were building. So Benny's first day was shadowing me in the hospital. It was a very busy afternoon in our critical care and trauma emergency department. We had one kid who came in, he was beat up pretty badly. He got stomped by a gang. This is a kid who was a nerdy skateboard kid whose family happened to be in a gang, and his family was warring with another family. And, I had multiple emergencies coming in. I spoke to the family, giving them updates on what was happening. But I had to run into another emergency. So Benny winds up going into that room to talk with the family. And at this point, the family's got gang affiliations. They're ready to go to war. And so Benny talked to them. This is the whole shift. He was just in there with them, talking to the mom, talking to the dad, talking to the other family members that were coming up, and really ready to go out and go back and get this other family who they had beef with. And Benny got these folks joking and laughing, but also understanding the serious nature of it and having them being open to support. That was his first case, and he wasn't even supposed to be working. And at that point, I was like, he's something special.
So you feel like you're really able to then, by being right there in the hospital, to take advantage of that second golden hour of trauma, that you're able to stop the spread of violence. Does it feel like it's working more broadly in your community?
I say yes on one half, and I say no. In another space, I say yes because now we're providing levels of support to people who didn't always have support in the hospital. I say it's not completely working because we're still seeing patients that are coming in. And, we spoke a little bit earlier about the nature of violence. We look at it as this disease process, but in order for these pathogens to really replicate themselves, you have to have the right environment. And unfortunately, until we have major changes as it relates to economic development and more comprehensive and higher level mental health support, and everything from access to education and better access to the decreasing and diminishing of food deserts, you're going to wind up having the most optimal conditions for intentional acts of violence to thrive.
Is there, you're a first responder and your violence intervention specialists are working to prevent the spread once the injury has taken place. Is there such thing as a targeted vaccination?
So yes, there are targeted vaccinations. My goal was to really create this hospital-based program with an after-school component for young people who may have experienced trauma and violence, and they can kind of have support groups, especially like for people who have been injured. There's a high school campus that's directly across the street on the other side of the hospital, and we decided to test our workshops with them. But I remember after 2 weeks, one of the guys said, Dr. Gore, he said, are you guys coming back next week? And I realized that we were onto something. I said, we can't take this out of the school.
What kinds of things were you teaching them?
The first thing was, how do we understand like some sort of emotional survival? And in order to do any of that kind of stuff, you have to figure out what is violence. So we talked to them about what is violence, what is trauma. We looked at everything from conflict resolution and mediation and skill development, and really to create tangible tools that was going to enhance survivability, but also create ways to optimize their well-being.
How well does it work? Is there a story you could share with us?
I can talk to you about Zane. Zane is one of my favorite people. Zane is a young man that we met in high school who was involved in a gang. One day we were doing one of our group workshops, and Zane, just had this look. He was sitting there, and he was usually very jokey, very friendly and pleasant to people. But he was sitting there, and he had this almost like a death stare. You knew something was brewing, but you didn't know what. And so I pulled him out of the room that day. I was like, this is number one priority. And we're like, what's going on? And he was like, so-and-so is not going to be here at the end of the day. He violated. And he said some other words. And I'm like, well, what happened? And he couldn't even explain what took place. But what we did find out was that he put a hit out on another kid. Think about 15, 16-year-old kids are putting hits out on people like they were some sort of mafioso. And I knew he had the ability to carry that out. And we talked to him dude, what's going on? And we talked to me and a couple of other facilitators, and he wound up calling it off after we had been speaking to him for a while. But I think we had 2 lives that were saved on that day, or multiple. And, Zane's case is a number of cases where we wound up mediating a major conflict that didn't get blown out of proportion. So I'm hoping that these systems that I am a part of, because I'm a part of a growing community of people who provide trauma-informed practices. If this becomes the norm where people understand how to process and engage people who've experienced trauma, we can minimize a lot of things, and we can start decreasing these injuries that are occurring or recurring after a violent incident has occurred.
Dr. Gore, thank you very much for your time. I really appreciate it.
Thank you so much, and I look forward to speaking with you again.
Rob Gore is an emergency medicine doctor in Brooklyn and founder of CAVI, Kings Against Violence Initiative. His new book is Treating Violence. An emergency room doctor takes on a deadly American epidemic. Now, we've yet to see what difference it could make to approach violence as an epidemic in America. But we've got 40 years of experience with another epidemic in this country.
It was a big part of our training, really talking about how the obesity epidemic is getting worse, and us as dietitians are going to be kind of on the front lines of helping people to reduce their weight and get to quote unquote a healthy weight.
Ahead on top of mind, has treating obesity as an epidemic actually backfired in America? I'm Julie Rose. We'll be right back. Hey friends, if you are looking for another great show from the BYU Radio family of podcasts, check out Constant Wonder. Host Marcus Smith takes you on an exhilarating journey through captivating stories of our magnificent natural world. You'll gain profound insight into different facets of our planet, discover more about nature, and maybe even ponder your connection to Earth's wonder. The show is Constant Wonder, and you can find it wherever you get your podcasts. When she started her dietetics training, Kirsten Morrison was fired up to be on the front lines of the longest and most widespread epidemic in America.
Really, I was looking for a way to crack the code on how to eat, quote unquote, perfectly and how to make sure that I didn't gain too much weight. I grew up with, a dieting mother, and everyone around me was dieting. And I got into high school, my body started changing, and I was like, okay, I guess, I'm going to focus on quote unquote eating right and moving more. So when it came time to decide what to study in school, I went down that path and I became a registered dietitian. I got my master's in nutrition, did a dietetic internship, and started working in the field, all really with its roots in my own disordered patterns around food and trying to find that perfect way of eating.
Obesity started rising quickly in the U.S. in the 1980s, and it was officially declared a public health epidemic in the late 90s. At that time, a little more than half of Americans qualified as overweight or obese. Today, that number has grown to 75%. 3 out of 4 adult Americans have overweight or obesity. 1 in 5 kids has obesity. Today, obesity is widely considered a disease itself and a major contributor to other chronic diseases that have increased substantially in the U.S. There's even some evidence that obesity is contagious within social circles. So it checks the boxes as an epidemic. But for all the dire warnings, public health initiatives, and the relentless marketing from the weight loss industry, America is heavier than ever. So right out of college, Kirsten Morrison got a job as a dietitian in a weight loss surgery clinic and pretty quickly began to question a lot of what she'd been taught about obesity and the value of treating it as an epidemic.
I stumbled upon the intuitive eating, health at every size field, and was really comparing to what I was seeing with the people sitting in front of me, all the struggles that they were experiencing, and just hearing of their episodes of yo-yo dieting, right? It's like the classic up and down with weight their entire lives, and hearing them tell me stories of, doctor after doctor telling them, you've got to try harder to lose weight. And I think weight loss surgery is your only option. So now you've got to do this because you've spent a lifetime trying to lose weight and you can't do it. So it's a lot of individual responsibility that was being placed on these people, and shame and guilt. By the way, even a lot of people who didn't have any problems with their health looked amazing. Their lab values were great. Their blood pressure was great, but they were told your body size is not okay. So that's what I was seeing on the before surgery side. After surgery, I was seeing a lot of folks that were struggling immensely with even eating the smallest amount of food. And sometimes they were eating such a little amount of food and still were not losing weight in the way that it was expected that they would. So they were, once again, they were telling me, I'm going to see the surgeon and they're telling me that I'm doing something wrong, that I must be eating more than I should be.
So what was all of this telling you then about the framing of obesity as this epidemic in America?
It was telling me that the way that we have been approaching health with this very weight-focused lens was backfiring. It wasn't motivating people to make sustainable, healthy, supportive changes for the long term. That was the biggest piece. And it was really questioning this belief that I had been told and that everyone is being told that, hey, if you're eating healthier, you're moving more, you're supporting your body, you will lose weight. And that's not actually what I was seeing playing out. I was seeing people make supportive, healthy changes. I was seeing changes in their lab work, and sometimes their body size was not reflecting the same thing, and yet their health was improving, right? So it's really getting down to the core of like, maybe weight and health are not tied in the way that we all have learned.
But how did you then start to make sense of the connection that has been drawn so clearly in scientific study after scientific study that says obesity contributes to this increase in other chronic health problems, that, you're at higher risk of heart disease, you're at higher risk of stroke if your body is over a certain BMI.
Weight and weight gain and being in a large body size is a confounding factor to these other disease states, diabetes, high cholesterol, heart disease, all of these things. It's a confounding factor. So as lifestyles, right, people are more sedentary, they're, eating quick, fast meals and all of these things, body size is increasing along with these disease states. Body size is being blamed, but the actual problem are these other confounding factors that are at play with our lifestyle and what's going on there.
She's not alone in thinking this way. There's a sizable community of dietitians and health scientists who now reject the idea that obesity is a disease. And they argue that calling it an epidemic has made things worse by prioritizing weight loss over healthy behaviors.
What I have learned since my training originally as a dietitian is that our bodies like to protect the weight they've already acquired. So for the most part, when you have done that yo-yoing of, okay, I lose weight on this diet and then I get, fall off track of the diet and I gain weight, and then I lose weight and I gain weight and I lose weight and gain weight. And over time, you're trending upward. And with each consecutive diet, you are gaining weight, and your body doesn't like to lose that weight that it has already gained, because at its core, it doesn't feel safe to lose weight. It feels like you're not getting enough. Your body is going to rebel against that. Obviously, there are exceptions to this, but for the most part, this is why we see so many people having so much trouble keeping weight off in the long term. It's because our bodies don't really like to do that for the most part for most people.
So Kirsten Morrison, when a client comes to you for coaching as a dietitian, and they say, I want to work with you because I'd like to lose weight, I want to have a smaller body, what do you say to that person?
Yeah, and this happens a lot, right? So what I tell them is, hey, I hear that you want to lose weight. I totally understand that. What we're going to do is we're going to get down to the root of why you feel like it is you want to lose weight. I always say to them, like, if you snapped your fingers right now and you're all of a sudden at the size that you want to be, what is different about your life? Well, I have more ease of movement. I can go out on a hike whenever I want and not feel like I'm going to lose, not have my breath. And I can run around with my kids and I'm eating in a way that feels really good. I'm not binge eating. I'm not emotional eating. I'm not eating out of control. I have time to cook meals. And then I say, guess what? We can focus on all of those things because those are actually behaviors and lifestyle things that you have control over. Weight is an outcome. It's not a behavior. So what if we focus on all of these things that you want and build in habits and figure out what works in your lifestyle and work towards those and allow your body to do what it's going to do.
But do they end up losing weight anyway?
Some of them do. If they stop binge eating and they start finding a joy in movement, yeah, some of them will lose some weight. Probably not the amount that they expect. Probably not, most likely not down to the quote unquote normal BMI, but their health is improved and their lab values are improved and they are happier and more peaceful around food in their body.
Have you ever had a client who's come to you for help and as a result they gain weight?
Yes, that has happened. Absolutely.
Is that okay?
Here's my take on it. I think that if somebody's been in a very restrictive pattern around food, they have probably really caused their metabolism to become very, very slow, right? They're not eating a lot, then they're binging later on in the day or whatever. And this very chaotic cycle. And then all of a sudden we start healing their relationship with food and we start talking about, hey, let's eat more throughout the day. Let's get that nourishment in. Let's reintroduce all these foods that you've been trying to restrict and then ending up binging on. So in the short term, yeah, it can cause this weight gain because of kind of the environment that you're in during this healing process. I really see that as an outcome of the system of dieting. I see that as an outcome of trying to lose weight for so long and being in a really disordered pattern with food and that impact on your metabolism. What intuitive eating will do every single time is find that stability with weight that you've been craving. Where that stability is is kind of unclear and is going to be different for everybody, but will get you out of that yo-yoing of up and down and weight and kind of gradual weight gain forever, and find a stable weight that your body is happy to protect. And I believe that that is the most supportive thing that people can be doing, because what I see with the clients I work with is they all of a sudden, after healing their relationship with food, they want to eat salad. They want to figure out, oh yeah, I do want to incorporate more vegetables and get more fiber. And like, they're able to think about these things because they're not beating themselves up and feeling all of this guilt and shame and just trying to stay away from the Oreos. Now they're like, yeah, I can eat Oreos and I can have a salad alongside my Oreos as a snack if I want. Like, all the rules are broken, and it introduces more opportunity for overall more nutrients coming in and overall taking better care of themselves, no matter their size.
Do you have clients coming to you now saying, I'm going to try the weight loss drugs? Because,
yeah.
And what are your thoughts about that? I mean, here's a way to have a smaller body that seems to work pretty consistently. And it seems like everybody's doing it, at least all the famous people who are touting their weight loss, right?
Yeah. So, I mean, a lot of things. First of all, just because you're eating less and don't have an appetite and your body size is going down, does that mean that you are optimizing your nourishment? Or are you now just like skipping a lot of meals, and then when you do eat, you get full really quickly and then you can go to bed and not overeat at night, right? Like, I think that there's just so much nuance is like in like that conversation of like, just because their weight is going down, does that mean they're improving their health? My other thought is this actually going to be effective in the long term? I'm highly skeptical. I worked in a bariatric surgery clinic, which when I was a dietitian, a baby dietitian in school, learning about all of this, I was told that weight loss surgery was the gold standard of weight loss. And guess what? That is not what we're seeing in the long-term data for bariatric surgery. We're seeing long-term slow weight regain, not over the course of a year, 2 years, 3 years maybe, but maybe over the course of 5 or 10 years. And I think the story is going to be exactly the same with Ozempic. I mean, if we talk, or any of these weight loss drugs, I mean, if we talk about weight loss surgery, I was mentioning one of the mechanisms is that it removes the part of the stomach that secretes that hunger hormone so people don't feel hungry. But guess what happens over time? Your body adapts, and the part of the stomach or the small intestine that is remaining starts to secrete that hunger hormone because your body is trying to survive and thrive and convince you to eat, because eating is a basic biological cue. And I think the same is going to happen with Ozempic. And in fact, I'm already seeing it. I'm hearing people coming to me saying, oh yeah, I was on Ozempic. It worked for a month or two. And then I started getting hungry again, and they had to increase the dose.
So what would you like to see? What should the public health response be to obesity in America?
I think it's taking a more behaviors-focused approach, right? What behaviors can we add in, and what is that going to look like in people's lives? Joyful movement, sports, fun, right? Like more sidewalks and more like, accessible ways of people moving their bodies, not talking about body size, but how can we get more nutrients in, have more accessible, convenient foods that are supportive for long-term health. The end result that we all want is more people, living longer and having quality of life and feeling good in their bodies and supporting their long-term health. But what is the impact of framing body size as a disease, as saying that obesity is an epidemic? People have got to lose weight. We've got to fix the problem of people's body size. It incites all of this shame, which prevents people from taking action and taking care of themselves. And we don't have a good way of getting people to do it anyway. We know that so many of these weight loss mechanisms are not effective in the long term.
Kirsten Morrison is a registered dietitian. She is the Intuitive RD online and host of a podcast called Intuitive Bites. Thank you so much for your time today. I really appreciate it.
Yeah, thank you.
Unfortunately, too many people who use drugs and have become addicted are treated like scum, and that drives them into the shadows. And unfortunately, if there's nobody there to find them, that many of them are dying. We can't treat this as a crime. We have to treat this as a disease.
Next up, why one paramedic says tackling the crisis of opioid overdose deaths as a disease epidemic is our best hope for saving lives. This is Top of Mind. I'm Julie Rose. Hey, Top of Mind listeners, I have another podcast I want to recommend to you. It's from the BYU Radio family of podcasts, and it's called The Appleseed. It's a show filled with stories for you and your family. Each episode features master storytellers sharing all kinds of stories: folk tales, fairy tales, personal and family tales. So it's perfect for road trips, for bedtime, or really anytime you're looking for something that the whole family can enjoy together. And the stories you'll hear will likely get your family sharing their own stories with each other, which is really the best part. It's the payoff. So listen to The Appleseed wherever you get your podcasts. To be considered an epidemic, something must first and foremost be widespread. Opioid overdose deaths clearly fit. In 2023, the U.S. hit a new record, more than 112,000 fatalities. Drug overdose deaths have quadrupled in just a decade, thanks to opioids. Longtime paramedic Peter Canning can point to the 911 call back in 2016 when he realized that things were escalating.
I remember doing a scene where, a mother was doing CPR on her child. And, I came in, there was a needle there, and, it was a young man. And that's what struck me was not that it was such a horrible thing, but it wasn't that uncommon.
They'd gone from dealing with a few heroin overdoses a week to several every shift.
And that's when I really started paying attention. I started, reading everything I could, talking to a number of different people. But it was only when I first started asking my patients, how did you get involved, that I really started to understand what was going on.
Peter Canning has been a paramedic in Hartford, Connecticut since 1995.
I'm also the EMS coordinator at UConn John Dempsey Hospital, and I'm involved in a lot of the opioid task forces in Connecticut.
In 2021, he published Killing Season, a paramedic's dispatches from the front lines of the opioid epidemic.
What happens now is it's not just, parents doing CPR on their kids. In some cases, it's kids doing CPR on their parents. It's really, really widespread. Basically, there have been three waves of the opioid epidemic. The first was prescription pills. OxyContin was promoted as, this is not addictive. Nobody should be in pain. It turned out it was actually addictive. And in about 2010, I think it was, what people were doing is they were taking the pill and they were scraping it down and snorting it or injecting it. So to prevent that, they made a tamper-resistant pill. And what happened was, the best intentions were to stop people from using it, but what they did instead is they shifted over to heroin. Heroin was cheaper, more readily available, and much stronger. So, about 75% of the people who were abusing OxyContin shifted over to using heroin. So that saw a number of deaths rise. But the third and the deadliest was the fentanyl. So fentanyl is a synthetic opioid. It's 50 times stronger than heroin. The drug is too potent for drug dealers to accurately mix. Within every batch, you can have bad individual bags because it's like the chocolate chip cookie syndrome. You get one cookie that's got 5 chocolate chips in it, and you got another that's got 30 in it. You could do 10 bags and get high, or you could do 1 bag and be dead from it. So the overdoses are like random, and they're all over.
Before Canning understood all of that, though, he admits he was harsh on people who overdosed.
I thought that they had a character flaw. I was scolding them. I was like, what's wrong with you? I stigmatized them. They were junkies, addicts, okay? But then I started learning about it. And I learned that addiction, or substance use disorder as it's called right now, is actually a brain disease. So what happens to people, we're programmed for 3 things, humans: to eat, to have sex, and to take care of our children. That ensures the survival of our species. What happens when somebody uses an opioid is it's like a 4th of July explosion of fireworks in their brain, and it hijacks their brain so that opioids become the key to their survival. That's what produces the dopamine. They no longer get that when they think about the other things. So once I learned that, I started to look at people differently.
Would you tell us about a patient that helped contribute to shifting the way you think about opioid use?
So one of the biggest ones was I went to a call for a car accident, car into a pole. When I got there was a young woman who was slumped over the driver's seat, and on the seat next to her there was a syringe and a bag of heroin. So I gave her naloxone, I revived her. I got her in the ambulance, and I'm talking to her. She's all upset. Her father's going to be angry with her. She's just gotten out of rehab. And she looked very familiar to me. And then when I asked her what other medical history she had, she said, well, she broke her back. Well, lo and behold, a couple years before, Friday night at a football game, she's a cheerleader. They threw her up in the air. They threw another cheerleader up in the air. Friday night, the homecoming game, beautiful evening. The first one they catch, everybody claps. She comes down, they drop her. There's silence. Her father comes down from the stands. Daddy, my back is killing me. We load her up in the ambulance. We take her to the hospital. She had surgery. They gave her these pills. She was out of school for a long time. The pills made her feel better. It got over the stuff that she was missing. And then in time, they cut her off. By then she's addicted to them. She's feeling sick, so she buys pills on the street. They become very expensive. So then the guy selling them to her sells her heroin instead. And then it goes on, and then here she is. But it made me wonder, how would the trajectory of life been different if they had caught her that day? She would have gone to the dance. She might have, graduated, gone to college, married, living in a white picket fence house. Instead, her dreams are going into a hole in her arm. And all these people, something happened that changed the trajectory of their lives.
What did that change about your response? What did you start doing differently?
Well, yeah. So one, I treated them better, and I feel ashamed that I treated them badly before. Mm-hmm. But, I would talk to them. And in many cases, I would explain to them what I had learned. Now, when I respond, I ask them, do you know where you can go to get help? If you are going to use, do you know where to get clean syringes? Do you know, to have naloxone present? And I try to treat people like normal human beings. And I unfortunately, too many people who use drugs and have become addicted are treated like scum, like addicts, and that drives them into the shadows. Most people who are overdosing, it's a complete accident. They're just trying not to be sick at this point. People said it's like being in withdrawal is like the worst flu times 100. And again, their mind is saying, I have to use. So in a lot of cases, they don't take all the precautions. But what do? You don't want your parents to know you're using. You don't want the people at work. You don't want your friends to know. So they hide when they use. And unfortunately, if there's nobody there to find them, many of them are dying.
And Canning says treating opioid overdose deaths as a disease epidemic opens the door to better interventions.
The war on drugs has been going on for 50 years now and has been a spectacular failure. The drugs on the street are deadlier than ever. More people are dying, and our prisons and our cemeteries are filled. It's great politics to say lock them up, but for policy, it doesn't work. A lot of people who overdose also have some problems with mental health history. But in general, to me, if I was to classify it as one thing, I'd say it's a poisoning problem right now that's really what's causing the deaths.
So what is the intervention then for a poisoning problem?
So you remember years ago in Chicago, a bunch of people took some Tylenol and died because they put cyanide in the Tylenol. All right, so the Tylenol was poisoned. So what did Johnson & Johnson do? They took all the Tylenol off the shelves, all right, to protect consumers. Now, the problem is this is an illegal drug supply. It's being poisoned, but how do we get rid of it? What some people would say, what we need to do is have a safe, regulated government supply. Now, this is happening in some places, like in England, they may have it. They have medicinal heroin. So, like if you're, have a family member who's addicted, rather than them going down to the drug market and buying, a toxic drug and using under a bridge, they go to a doctor's office or to a government-regulated place, and they buy a prescription manufactured so that they know exactly how much that they're using. All right, that's going to end the deaths. But politically, that's not going to happen because the political climate is that the people aren't educated enough to understand that this is a disease. This is not a character flaw. But that's how you do it. And a smaller way is you have what is called overdose prevention sites. They have some in New York, they've had some in Canada, where people who use drugs, they go to a specific building, they use the drug, where health workers watch them. If they overdose, they get naloxone right away. They also have a medical person there who can look at their abscesses, can talk to them about their problems, can help get them into treatment, get them housing or whatever. Nobody's ever died in any of these places. They have a great record at getting people into treatment.
So the two solutions that you've identified that could truly end the poisoning deaths, one would entail the United States government making safe heroin and somehow selling it through prescription, which is, like you said, very unlikely politically.
Sure, yeah.
And the other one is to have sort of widespread and easily accessible safe injection sites, safe usage sites. And to that one, the places that have tried it, no one dies on the premises, but the neighborhoods where these end up being do experience a lot of public use, even in places where opioid use has been decriminalized in Vancouver and in parts of, in Oregon. They're reversing that because what they've ended up with is a lot of the ills, the public crime and the public use and the sort of unsavory, unsafe nature of it. You've brought it into the open, and overdose deaths have continued to climb.
Yes. So to look at Oregon, what's going on there? The overdose deaths have gone up. They have not gone up due to decriminalization. They've gone up due to the arrival of fentanyl.
Yeah. That's
why the deaths are going up. The public usage and stuff, the problem there is homelessness. It's not the drug problem. Now, I agree that they should, they got to have something where people are not using openly in public. But you have other areas of the country that don't have high levels of homelessness, don't have the high levels of people using out in public. If people are homeless, they have nowhere to go. Yeah. And the homeless life is hard. If you address homelessness, you can get a lot of people off using drugs. So sure, a safe supply, safe use sites, those are big. But the two biggest things is treatment, making treatment available, particularly medication-assisted treatment, buprenorphine and methadone. Right now, a very small percentage of the people who have opioid substance use disorder are receiving treatment. We have made it very difficult for people to get on methadone or Suboxone. That's changing. They're opening up the access. But very few people are on these drugs that truly work. They're wonderful, evidence-based, they work. There's a lot of stories of people trying to get into treatment, and it's like, here's a waiting list of 3 weeks, and then they die, in the meantime. And then stigma. I think we have an epidemic of unkindness in this country. And I think there's a lack of compassion. And I think that the politics of the country have been such that people, we don't really care about our neighbor anymore. And I think that we need to show that empathy. And I didn't have it when I began as a paramedic, but I try to pass it on to today.
So what is your advice to the family members or to the friend who was doing CPR on their loved one when you showed up? You administered naloxone, you revived the individual. What is the conversation you have with the family members about what they can do to try to save the life of their loved one?
First of all, I'll say you need to have naloxone in your house. And they might say, well, I don't need it because my son's clean. He just got out of rehab 3 months ago. And it's like, well, most people relapse at some point. It's part of the journey. So you need to have naloxone, and you need to know how to use it. Additionally, you might want to, talk with your kid, and it's like, if you're going to use, please don't lock the bathroom door and use it when I'm not home. If my daughter was using, I would want her to use next to me at the kitchen table with the naloxone right there, so I could watch her, ensure that she was safe, than having her, using under the bridge by herself, or somebody finds her body 3 days later.
And you wouldn't feel like you were enabling her in any way? I'm
enabling her to stay alive. We have to remember, we can't treat this as a crime. We have to treat this as a disease. There's a part of the Hippocratic Oath that I particularly like. It says, into whosever house I enter, I will enter to help the sick. And that's what we have out there. We have people who are sick. All right, these are not scumbags. These are not criminals. These are people who have had hard lives, that something happened to them that set them on a trajectory that no one could have anticipated for them. And it's our job to take care of them.
Peter Canning is a longtime paramedic in Hartford, Connecticut, and EMS coordinator at UConn John Dempsey Hospital. He's author of Killing Season, a paramedic's dispatches from the front lines of the opioid epidemic. So now to the newest of the public health epidemics in the U.S., and it's one that's linked to other high-profile concerns, such as rising rates of depression, anxiety, suicide, and what have been called deaths of despair.
What we see is that Americans are spending significantly more time in isolation.
Julianne Holt-Lundstad is the nation's leading scientist of the loneliness epidemic.
We're also seeing significant reductions in time spent with family, both household and non-household family. Significant reductions in time spent with friends. And this trend has increased over the past 2 decades.
Holt-Lundstad is a professor of psychology and neuroscience at Brigham Young University, and she was the lead scientific author on the U.S. Surgeon General's 2023 advisory that officially declared loneliness and social isolation an epidemic in America, and offered recommendations to treat it. Now, Holt-Lundstad says loneliness is not inherently bad. It's a basic biological signal.
Much like hunger and thirst, that drives or motivates us to meet our social needs. However, when it becomes persistent over time, that can lead to a whole host of negative outcomes.
Right. So starvation can kill you. If you don't eat when hunger tells you to eat.
Yeah.
So can lack of social connection kill you?
Yes. And we have robust evidence of that. And what we find is that those who lack social connection have significantly increased risk for earlier death. So in one of my meta-analyses, this included data from over 3.4 million people worldwide. We found that loneliness increases risk for earlier death by 26% and isolation by 29%.
In other words?
Lacking connection is on par with smoking up to 15 cigarettes per day, excessive alcohol consumption, and some of these other risk factors that we take quite seriously for health.
Does that surprise you?
Not really, given when we look at social species in nature. Being part of a group is essential to survival. Being part of a group, you can evade predators. It's protection from the elements. It helps in obtaining food, efficiency of resources. Being outside of that group is a very vulnerable place to be. And our biologies have adapted to expect social proximity. And so when we are alone or we're not with trusted others, our brains need to be more active, more vigilant to meet the demands of everyday life on our own, which can have cascading effects and dysregulating effects. So if we have dysregulation in, let's say, our cardiovascular or inflammation, inflammation is really adaptive in the short term, but when it is becomes systemic and chronic, that has been linked to depression. It's been linked to dementia. It's been linked to cardiovascular disease, a number of chronic kinds of conditions. And so it's no wonder that we see that even lacking connection, isolation, loneliness has been linked to such diverse kinds of mental health, cognitive health, and physical health outcomes, because oftentimes these have common mechanisms.
And so, who are the first responders in the loneliness and social isolation epidemic?
We can all be. In fact, one of the things that we talk about in the advisory is that just even knowing your neighbors in times of crisis, whether that's an earthquake, a flood, a fire, they will often get there before trained personnel and can often be a matter of life and death. Healthcare providers often encounter individuals struggling within their practice. And What's unfortunate is oftentimes healthcare providers lack the training and resources to deal with this. We have published framework and guidelines for healthcare providers, but those first responders also might be elementary school teachers or university, and they may be the first responders seeing their students struggling. Interestingly, one of the things I hear all the time, even when I've been speaking to both healthcare providers and educators, they'll often say, we don't want to just help the people we're serving, we're struggling ourselves. And so, the physicians are struggling, the teachers are struggling with isolation. And so our larger organizations need to be the first responders as well.
What would be an example?
That could be workplace policies around normal working hours and opportunities for leave, or how on call you need to be outside of normal working hours.
That could be cutting into your social connection outside of work.
And there could be even policies within work that might limit how you engage with others to develop connections at work, right? That certain performance things are individual based versus group, or, whatever it might be that might influence how connected or not connected people are.
And communities can build themselves to be pro-connection too, says Holt-Lunstad.
The physical places and spaces to interact with others, whether that's a park or just even walkable streets. A lot of, for instance, buildings get unused during certain times of the day or certain times of the year. And if we could change that so that those spaces could be used as social spaces when they're not being used, that could open up, new opportunities for people to socialize, for example. But we recognize that you could build spaces, you could implement programs, but if it was inconsistent with the norms, that these would all fall flat. If people don't value connection, if they don't value the kinds of values that go along with connection, like kindness and respect, we're not going to have the success that we want. And so it really is about, modeling this. And we actually, I did a study where we looked at the US, UK, and Australia, where we asked people to do random small acts of kindness for their neighbors over the course of 4 weeks. And what we found was that when people did small acts of kindness, it reduced loneliness, it reduced conflict, and it increased the likelihood that people knew their neighbors. And we only measured the person doing the acts of kindness. So presumably the person on the receiving end also benefited. And so these small acts of kindness can have a cascading effect. And so even though it feels like, especially as we talk about an epidemic, it feels so huge, and it also feels so perhaps insurmountable. But then when we think about just doing something small today, smiling, asking someone how they're doing, offering to, help someone with their groceries, whatever you might encounter in your daily life, those small acts of kindness can start to create more of a culture of kindness. And so that's how we get these pebbles rolling and hopefully making a bigger difference.
Julianne Holt-Lunstad is a professor of psychology and neuroscience at Brigham Young University, and she's the founding scientific chair for the U.S. Foundation for Social Connection and the Global Initiative on Loneliness and Connection. Did you hear anything in the episode that challenged you? Well, reach out if you have. My email address is topofmind@byu.edu. If you've had a stick-with-it experience lately, we are actively looking for more people to feature on a brand new podcast we're launching in July. It'll be called Uncomfy, Sticking with Moments That Challenge Us. Top of Mind is a BYU radio production. Today's episode was produced by Amber Mortensen, Samuel Benson, and me, with help from James Hoops and Sam Payne. Our audio engineer and sound design team includes Kelsey Ney, Brandon Lewis, and Trent Reimschissel. I'm Julie Rose. We'll talk again in 2 weeks.